Okay, guys. So we will start. So this just a disclaimer. Just this lecture is was initially meant for medical students. فشوية it's very basic. If it's too easy for you, طبعا ask questions. We will elaborate to according to the questions we'll answer. بعدين it will get more complex. بس هو الصراحة it's a simple lecture. بس طبعا still very relevant. Okay. Just couple of housekeeping rules. Another ECG introduction that I had given before is on YouTube, and this is the link. Okay, so just for people who are interested, please you can have this link and and attend that lecture. Okay, so this is a new format. So you will see there are a couple of cases. Each case, of course, there's an ECG in the case. You have to open your phone and direct the camera on the QR code next to the ECG. Okay. So again, open the camera app, direct your camera onto the QR code. But then once you do that, you will see a link that does say openforms.office.com, and then you click that link, and then there is a question for that ECG, and you submit your answer so that we know how many people are answering and how are they answering. Okay, so it's it makes it more fun. Okay, guys.
Yeah.
Anyways, okay, so please everyone try to answer the questions. I mean, there are no names, so don't worry, just answer whatever you know. Okay, so the outline is we will show a couple of examples for emergency arrhythmias, and then a couple of examples of less emergent but still urgent arrhythmias, and then a couple of ECGs that with findings that you should not miss, and then others miscellaneous findings. Okay, so again, so this is the first ECG, case number 1. This is a 16 years old. I will not say the history now, because if I said the history, it may give away the answer. So please spend a minute or two and answer the question. Let me know if there are technical issues. Okay. Oh, sorry. If you guys are done, let me know, because I cannot see. Well, let me see. I cannot see how many people answered unless I exit the screen. So everyone answered or not yet?
Not yet.
Okay, yeah. You need I will give you another minute or two. Okay. These are again easy ECGs, so don't overthink it. There should be.
Dr. Mohammed, again, Dr. Mohammed, again, how to scan? How to scan?
Okay, open your camera app. Open your camera. Pretend that you are taking a picture of this code, QR code. Okay, and then you will see a link.
Okay, done.
Okay. Okay. Now we have 9 participants, so everyone did it. Let me see. Okay. So I will leave the screen and I'll see the answers. Okay. ECG2. I mean, this is the first time I'm doing this, so bear with me a little bit. Okay.
معلش again تاني يا دكتور محمد. دقيقة واحدة بس.
I'm failed, Dr. Mohammed, to go any web, any site.
You cannot do it.
Maybe
how to open the camera, Dr. Muhammad? How to open the camera? we are using the same mobile.
we has already QR code in the mobile.
يا علي
يا علي just open the camera.
حط الكاميرا يا علي على السكان الكود ده، هيطلع لك فوق لينك على طول جاهز كده، اضغط عليه
دوس عليه.
Yeah, it's so easy.
هي تلقائي هيطلع لك يا علي لينك.
Yeah.
But when I open the camera the zoom link disappear.
الكاميرا لوحدها هتعمل زوم على تلقائي على
انت
الباركود ده.
you're using your phone. Okay, don't use
He's done.
انت ميرفت you're using your phone, right?
يا ريت الاي سي جي يا دكتور محمد بعد اذنك.
ايوه
Can you
Yes, done.
Okay, sorry. Can you have your Mervet? You need a laptop with you. Better. If you don't have a laptop, then you cannot participate. Okay.
تمام شكرا.
Okay. So let's see the answer. So this is the first time I'm
ما
doing.
لحقناش يا دكتور محمد.
لسه. Okay.
ECG again. Yes.
يلا. Okay.
هناخد وقت.
Yeah, but you cannot spend 10 minutes. You have to be quick, huh? 2-3 minutes max. Otherwise, we will not finish.
Age Dr. Muhammad, age.
Age 16.
16 years.
Yeah.
Yes.
There's a baby. I don't know who is Ali. This is your baby?
And I mute the mic.
Okay. Done? Okay, I'd see no responses. So that's, I don't know why. Okay, so.
Dr. Muhammad, I sent you on private message on chat.
So you guys, all of you submitted answers? Did you submit?
I cannot submit.
Done.
I don't see any submissions.
No, done.
No, I can submit.
I submitted. Dr. Muhammad also submitted. Yes.
Okay, so there's technical issues. And this is the first time I do this. I do see 0 responses. I don't know why. Okay. We'll try the other one. Inshallah, the other one works. But that's strange. Oh, ECG 1. Yeah, I don't see any.
الاستجابة ضعيفة قوي بعد submit بيحمل كتير.
So it maybe takes time
بيحمل
Okay, anyway, so that's not, let me see, let me try myself. Submit. زين.
Is it another case?
لا هو المفروض هذا بس حتى أنا شوف I submitted بس I don't know why it's not working. Okay, anyways, that's fine. I mean, it's good that we are maybe.
هو ليه طالع؟ أنا طالع عندي ECG 2. أنا مجاوب على ECG 2 كده.
I know. It should be ECG 2. Okay.
Can anyone help me because I can't submit or I can't open the camera in the same time.
خلاص, okay. شكله first there is technical issues. I don't know what's wrong. So I'll try to figure it out later. Anyways, okay. So what did you guys think? What do you see? Someone can volunteer.
هو ده sinus rhythm. أولاً sinus rhythm.
Okay.
Hello. Normal right axis deviation.
90 degrees, sure. 90 degrees. مو right.
في some ST segment changes بس ده اللي أنا شايفه.
Okay, حلو.
كده أشوف أي حاجة تانية.
So there's S segment changes. Perfect. So when you see S segment changes, what comes in mind? What do you? How do you clarify that?
And maybe ischemia.
Okay, hello.
Ischemic change.
What else could it be?
Early rubberization.
Okay, hello. Early rubberization. In other words, the canine. من اللي عنده كيد.
وabnormal Q wave في lead 3.
شلون؟ abnormal what?
We have abnormal Q wave.
Where?
lead 3.
Lead 3. Deep
more than كبيرة شوية طويلة.
Yeah. Usually less than 7 is fine.
بس only one lead ممكن تبقى insignificant.
Yeah. شوف الطويلة it's not as important as wide. The wide is more relevant compared to the height of the Q wave or depth of the Q wave. Okay. Less than 7, sometimes people say 8 small squares. That could be fine as long as.
شاكك في حاجة تانية برضه يا دكتور محمد.
شنو؟
في حاجه تانية شاكك فيها برضه.
قول يا دكتور اسماعيل قول.
قول
شاكك ان هي تكون بيريكاردايتس، وفي يعني البي ار ديبريسد شويه،
اوكي حلو. ف بي ار
مايل ديبريشن.
ST segment changes could be يعني قلنا ischemia, early reposition or pericarditis. Perfect. Okay. زين. ف just to orient your thinking, so whenever you see ST segment changes, guys منو عنده اياها اليمه؟ ايوه. Okay. When there are ST segment changes, these ST segment changes could be pathological or non-pathological, يعني meaning significant or non-significant. If they are non-pathological, your differential, usually they could be, يعني, it could be because of early repolarization. It could be whenever you have an abnormal depolarization. بمعنى you have patient with bundle branch block, you have patient with WBW, because the QRS is changed or abnormal because of the WW or the bundle branch block, the repolarization also gets abnormal. So when you have depolarization that is abnormal, your repolarization by default could very well look abnormal. So it's meaningless. You cannot assess your repolarization if you have a depolarization problem. For example, if you have a patient who underwent tetralogy repair, has right bundle branch block, oftentimes you will see ST segment changes within the right bundle branch because of the right bundle branch block, but you cannot assess this patient is having acute ischemia or not. You have to assess the patient in terms of ischemia by other means. For example, obtaining history, troponins, and then rule out ischemia by imaging. Okay. So if you have an abnormal depolarization, your repolarization may very well be abnormal, or it could be an early repolarization variant, or if there's a minimal change, and I'll define what do we mean by minimal, then this could also be non-pathological. So just to elaborate further, the minimal depression or elevation that I just said that I will define, less than 1 small square in the limb leads and less than 2 small squares in chest leads. So if you have an elevation or depression in one small square in limb leads or less than 2 small squares in chest leads, then this could be a normal or non-pathological ST segment change or normal variant. Okay. Early repolarization means, or usually is seen in young individuals, young teenagers usually, and often seen in the lateral leads and inferior leads. Okay. There are usually tall T waves, and the T waves are upright, and along with if the ST segments are elevated, and the T waves are depressed or negative if the ST segment is depressed. So there is ST or ST-T wave concordance, yani they go together. If there's ST segment elevation, the T wave would be upright. If there's ST segment depression, the T wave would be negative. That's normal or non-pathological ST segment change. And the T wave looks very normal, except it's a little bit tall, okay? So here, for example, there's a little bit of a segment elevation with a upright T wave. A little bit of a segment elevation, upright T wave, okay? A little bit of a segment depression, negative T wave. So there is concordance between them. And then, there is this smiley shaped S segment elevation that's benign looking S segment elevation, okay? So whenever you see such finding, don't panic, especially if the patient is here for something else and you do a screening ECG. That's usually the patient is not inactive ischemia if he's not complaining, okay? However, if there's a pathological ST segment change, there is discordance between the ST and the T wave. For example, you get ST segment elevation with T wave flattening or depression, or you have ST segment depression with T wave being upright, and so forth, okay? And then the ST segment are dynamic. If he's exercising, it may get exaggerated, and if he's resting, it may go back to normal. So then it's physiological change, and this could signify ischemia with exercise, okay? So for example here, so you guys tell me, do you guys think this is pathological or non-pathological ST segment change here? Anyone can.
Pathological.
Pathological.
Hello. Yes. So you have a segment elevation with T wave that is inverted.
Yes.
A segment elevation with T wave, yani funny looking. A segment elevation T wave that's inverted. Okay. So discordance with the ST and T wave, that's very significant. Okay. Often it's yani, in a specific coronary artery distribution. For example, here it's like inferior leads. Okay. And lateral leads, for example, or lateral leads. And what about this ECG? Is it pathological or non-pathological, you think? The ST segment change.
looks pathological.
Hello.
لا
Yes, because it's depression, biphasic T wave, depression, upright or biphasic T wave, depression, biphasic T wave, okay? Depression and upright T wave. So there is definitely discordance between the ST and T wave, T waves, okay? And again, in this case, for example, the lead one, which is left lead, AVL, left lead, both are having the pathology, okay? So you know there's something on the left side, okay? And also V6 is the left side. So there is left, you know, left infarct or left ischemia. So again, it follows a specific coronary artery distribution, okay? Okay, in this case, a segment depression, not elevation. Okay, okay, so back to this patient. This patient was, you know, this is a true patient. And he complained of sudden retrosternal chest pain. The pain was very severe, so people gave him morphine. It was very severe pain, non-reproducible. He had a troponin leak, but minimal, but troponin leak. And then MRI was done, and there was, in fact, gadolinium enhancement at the mid-inferior lateral LV free wall, okay, suggestive of myopericarditis. So again, the MRI finding makes sense because the ECG also is suggestive of left lateral to inferior, because inferior leads and left lateral leads, right? So the ECG is, the ST segment distribution is very, they confirm the MRI finding, okay? So in this case, yes, it may, at the first glance, if you don't know history, you may say this patient has early repolarization because again, he's a young individual. And then we said the ST segment change is in left and inferior leads. And in this case, there is concordance. ST and TOS are definitely concordant, except in lead 3, it looks funny a little bit, but otherwise it's concordant. However, if the patient tells you I have an acute chest pain, it's very severe, sudden onset, I mean, feel free to do troponins because no one would criticize you if you were worried enough to do, you know, to check for myocarditis. And there's PR depression, like what Ismail was saying. Again, PR depression may suggest, of course, any pericarditis and or perimyocarditis. Okay, so this patient had, true perimyocarditis that is very mimicking early repolarization pattern. Okay, so history is very important. If your history is very benign and you see such an ECG, you may call it early repolarization. But history is suspicious, regardless of the ECG finding. Feel free to order troponins and make sure there's no myocarditis. Okay, guys. Okay. Question? Okay. Let's try.
Clear.
Okay, let's try the other case. Hopefully it works. Okay, let's do this exercise again. Try to submit your answers. Hopefully, I don't know why, but hopefully now it works. I have to figure it out for next time. Okay, 1 day old. He had history of fetal tachycardia, born with decreased function, and he had an arrest.
Rate how much يا دكتور محمد؟
Well, you tell me.
أنا قاعد في 10 مربعات كبير.
يعني something fast. Okay, someone is writing my screen.
Okay, خلاص.
Oh, okay. something fast يعني. يعني 250 roughly 250. Okay, let's see whether enough time. I'll just see whether this is working. ECG 14. ECG 14. It's not working. I don't know what's wrong with it. Okay, oh, I have 3 responses. Oh, that's good. So now it's maybe it's just slow. So only 3 people answered. Yalla, I'll give you more time. This is an ECG, it's not that difficult. Okay, 4 responses. Yalla guys, less than 50% are answering. Okay. يعني خلاص, no one want to answer more? Okay. Let me refresh. So good. So I at least, so can you see my screen now? Or no? You guys see my screen? Hello? You guys see my screen here?
Yes.
Yes? Okay. So 4 responses, everyone said VT. Perfect. Okay. So, so that's a patient of ours, yani chest hospital, I mean. This is a patient who had fetal tachycardia. Interesting patient. Had a fetal echo only 2 times, at late gestation, I think 34 weeks or something. So initial fetal echo was at 34 or 32 weeks. They did diagnose him with tachycardia. They gave him flecainide, and then they repeat the fetal echo a week or 2 later. He was still in tachycardia. Function was depressed, so we induced the patient. He was born. When he was born, he was not in tachycardia. Instead, he was in 2-to-1 heart block and plus AV node 1 kebab and 2-to-1. So he was bradycardic with some degree of heart block. So strange, tachycardia in utero, born with bradycardia, strange. But then soon, a couple of hours later, he did this rhythm, and then he was pulseless. So long story short, this is, obviously wide complex tachycardia. It looks very ugly, and then it should be VT until proven otherwise, okay? And knowing that he has AV node disease, SVT is very unlikely. SVT with aberrance is very unlikely because the AV node is not healthy. How would you expect his AV node to conduct very fast, heartbeat if at baseline there is 2-to-1 conduction or AV node 1 kebab, right? Makes sense? Because whatever SVT he has, often AV node is part of the circuit, okay? So if you have a patient with AV node disease and suddenly gets tachycardic, it's usually VT until proven otherwise. The tachycardia is coming from below the AV node, okay? Makes sense? And in this case, it's very wide tachycardia, and there is a hint of AV dissociation, meaning there are P waves that are marching through, without conduction, okay? Anyways, so this is, ventricular tachycardia. It's wide complex tachycardia. In this case, it was unstable. He was pulseless, so we shocked him. But usually, if the VT is stable, of course, there is nothing wrong with giving adenosine for a patient with wide complex tachycardia that is regular. Okay, regular. There is regular is pay attention to كلمة regular. If the patient is in wide complex tachycardia that is irregular, adenosine may be contraindicated. Why is that?
اديني يا دكتور محمد معلش.
if a patient
هي ريجولار دي اللي هي تورسيت بوينت يا دكتور محمد ولا ريجولار دي اللي
if a patient is in irregular wide complex tachycardia, why is it dangerous to give adenosine for that patient? Or potentially
Because it will produce AV block,
هارت بلوك.
increase the
عشان
arrhythmia.
كده هدي فرصة للابنورمال باث واي.
Yeah. So if you have a patient, you know, when you have an irregular wide complex tachycardia, one of your differential, especially in pediatrics, is something called pre-excited atrial fibrillation, or someone in AFib with WBW. You heard of this before. We mentioned it before, if you remember.
Yes.
Yes. Okay. So if you have a patient, this is his beautiful heart.
شغل الابنورمال باث واي اكتر.
You have a patient here. Okay. He is in AFib. Okay. He is in AFib. And then this is my drawing for AFib. And usually, if there's no accessory pathway, the AV node طبعا transmits couple of some AFib signals, but usually the AV node is smart and slows down the heart rate as it doesn't conduct one-to-one. So in other words, patient doesn't go to 300 beats per minute, 400 beats per minute, because the AV node decrements, blocks many AFib signals. Okay, it's a protective, it's something that protective for the patient. However, if there is an accessory pathway, that accessory pathway is not as smart. Often, it has the ability to conduct, way more rapid than the AV node, and the patient may have a heart rate of 300, 350, 400 beats per minute. In other words, the patient is fibrillating. There is no, the ventricular rate is so fast as if there is no cardiac output. Okay, there's like kind of VFib. Okay, so pre-excited atrial fibrillation is a differential when you have polymorphic VT. بمعنى طبعا why is it polymorphic irregular wide complex tachycardia? Why? Because طبعا irregular he's in AFib, and wide complex because there is WBW, so the QRS is wide, right? So if you have irregular wide complex tachycardia, and you give adenosine, so you block the AV node, then you encourage the AFib signals to go down the pathway even more. So you may convert the patient from stable AFib with WBW into VFib. Okay, guys? So again, if you have wide complex tachycardia that is regular, your differential could be SVT with aberrancy, so there's no harm in giving adenosine, especially if the patient is stable. However, if you have a patient in wide complex tachycardia that is irregular, you should think twice before giving adenosine, because pre-excited AFib is one of your differential. Unless you definitely is sure that there is no WW, then sure you can try. But if you're not very sure, you should not give adenosine. Make sense, guys?
We'll give amio, Dr. Muhammad.
Well, yeah, in that case, then you can give procainamide or amio. Okay. We don't have procainamide here, so you should give amio or cardiovert. Okay. So again, VT, if VT is stable and regular, you can give adenosine, and then you give drugs, of course, or you do synchronized cardioversion. Okay. If the patient is unstable, like our patient, or he's indeed in VFib, or there's pulseless VT, of course you have to defibrillate immediately. There's no time to give drugs. Okay, guys? Okay, so in this case, we shocked him. Okay, just really quick, we had mentioned this before. If you have, there are a couple of rhythms that are non-shockable, meaning, not each and every arrhythmia you just try to shock the patient. There are contraindications to shocking. For example, if someone is having PEE, pulseless electrical activity, meaning he has a nice organized ECG, but he has no pulses, you should not shock him, because there is normal electrical activation or organized activation, but there is no cardiac output. So there is myocardial disease, that there's no contraction. Okay, not because there's electrical disease, just the myocardium is very sick. Okay, if you have asystole, of course you should not shock anyone who is asystolic. Or if you have automatic tachycardias, remember we said this, if you have jet junctional ectopic tachycardia, you should not shock. There will be no response. If you have automatic atrial ectopic tachycardia, you should not shock. There will be no response. If you have multifocal atrial tachycardia, often there will be no response to shocking, okay? So not each and every tachyarrhythmia responds to cardioversion or defibrillation, okay, guys? Of course, if the patient is bradycardic, then you do CPR and epinephrine and atropine and so forth, okay? Okay. Any questions so far? These are the main two, all these ST segment changes and VT that is unstable, هذيل emergencies, you have to react fast. Otherwise, each and every arrhythmia, you can take your time, analyze the ECG, drink your coffee. بعدين don't people often react so quickly to something that's not very emergent, and then they panic or they don't look at the ECG very well, so they misdiagnose the ECG. Okay, so as segment changes VT, of course, react immediately. Otherwise, you have to, you spend some time and analyze the ECG and then react. Okay, okay. Case number, I guess 3. 4 weeks old who came to the ER with frequent vomiting. Guys, everyone try to answer because we need more responses, okay? I'm answering with you. For these 4, one of them was me. And again,
يا دكتور احمد بس ممكن حضرتك تجيب الكود في نص الصفحه؟
Why?
مش عارف، مش شغاله معايا نتورك.
Right, they cannot see the ECG.
اتحرك انت كاميرا يا علي.
Right, the people cannot see the ECG. Everyone? Okay, let's see. ECG 13. Well, I think part of the issue, the internet is slow. I don't know, my internet or your internet or the system is slow. Look now, 0 responses. So you guys submitted something, right? Oh, there are 5 responses, sorry. Okay, so interesting. So 3 people said SVT. Yeah, 2 people signed tachycardia, 1 atrial tachycardia. Okay, good. So we have a mixture of answers. Okay, who said sinus tachycardia? Can you say why? منو قاعد يلون على الشاشة؟ ترى مو أنا. I don't know who's doing this. Someone is. Let me erase this. Okay, so who said sinus tachycardia? You might be right. فيعني speak up.
انا قلت ساينس، انا اخترت ساينس.
Okay, حلو. Why?
Why؟ لان انا كنت شايف I can identify B wave in some leads.
Okay, point.
But I can't.
Can you point, by the way, or you cannot? Can you try to point? يعني can you point? يلا point. Where are the keywords that you're looking at? Okay.
هنا.
Where? Okay. زين. Okay, so you see it all the time?
هنا. لا مش قلت not also sign.
حلو خلاص. Okay. So you think this is a P wave, صح? This is more deflection, right? صح?
Yes.
Okay. زين. You don't see it here. You don't see here. There's artifact. Okay, go up. I always cheat. Go up here. في something here?
لا I can't identify in lead one.
Okay. فيعني this is very likely it's just
عشان كده تبقى SVT.
Yeah, this is very likely it's artifact. لأن again, if this is a P wave, there should be a P wave here. You don't see, and this is a clean lead, ما في P wave. Okay. here there is artifacts. Okay. فيعني plus
not
الهارت
clear قوي صح.
الهارت is proven 240. Okay. يعني sinus tachycardia 240 is almost impossible يعني. Okay. Usually it has to be below 220 يعني.
Yeah.
Okay. It's very, I mean, I don't think it's possible to get sinus tachycardia at 240. Okay. The heart rate is against your diagnosis. Plus, this is just artifact. Okay. Well, atrial tachycardia, I don't know whoever said tachycardia. Atrial tachycardia means there is an A, then QRS. A, then QRS. Again, where is your A that, يعني, look at the clean ECG. ما في A below.
هو البيشنت ده ديكستروكارديا يا دكتور محمد الأول؟
Why do you say dextrocardia?
عندنا هنا البي ويف مش كلير في ليد 1
ما في.
بس هي بوزيتيف في اي في ار.
انت يعني again يعني are you sure you're seeing P waves؟ هني السؤال.
ولا الاكستريم
lead 3 شوف lead 3 و lead 2 are very noisy. So I would not يعني see them super well. But look يعني there is definitely no P wave before the QRS. Okay يعني it's difficult to see a nice clear P wave. طبعا you could argue يعني we could look really hard and we can imagine P waves of course, but definitely there's no P wave before the QRS. Okay هذا ده يعني immediately before the QRS there's no يعني if you have sinus tachycardia usually the PR is very short and someone is يعني nervous. فالP تكون على طول before the QRS وطبعا normal looking P. So here there's definitely no P wave or normal looking P wave, and if there is a P wave, the PR is not very short. It's against sinus tachycardia. Plus the heart rate is very fast for sinus tachycardia. Okay, so many things are against sinus tachycardia. And then atrial tachycardia again, you should see P QRS T P QRS T P QRS T. So here you don't see P convincingly. You don't see P that that suggests tachycardia. Plus tachycardia is often irregular. Here it's very regular. Okay. فيعني tachycardia definitely a possibility, but down the list. SVT, reentrant tachycardia. In this case, this is an example of textbook reentrant or SVT, or in there's an accessory pathway, tachycardia going down the AV node up the accessory pathway, down the AV node up the accessory pathway, which is very common in babies. Okay. So the answer is SVT. Okay. So most of you said SVT anyways. So that's good. But sinus tachycardia are definitely, and you should be thinking of such diagnoses, but not in this case. It was not the case. Okay. So SVT, it's a usual complex tachycardia. بمعنى if the patient has tetralogy repaired, has a baseline right bundle branch block, then his tachycardia would be wide complex tachycardia because his baseline QRS is wide. Okay. In other words, use the term usual complex tachycardia because it may be wide but still SVT. Make sense, guys?
With appearance.
No. If you have
called it with appearance, SVT with appearance if there is a bundle branch block.
Right, but I'm not saying appearance. I'm just saying a patient with a patient with intrinsic blocked right bundle because of surgical
yes.
Then of course his SVT would be wide. Okay. So when you see usual complex tachycardia, something tachycardic usual complex without identifiable P wave, of course P waves are always there. Sometimes they are hidden in the QRS, but very often they are after the QRS. So you can often see the P wave. But for the medical student level, for the non-cardiologist level, the teaching is you cannot see P waves. But in reality, we almost always see P waves. Okay, guys? Anyways, if you have difficulty seeing P waves and you have a usual complex tachycardia and it's regular, then this is SVT. Okay, or your differential would be, the first differential would be SVT, and you do vagal plus minus adenosine. Okay, guys? That's easy, right? So here, and this is a tachycardia, you don't see nicely P waves. and so you give adenosine or do vagal and see what happens. So if you give adenosine or you do vagal and it terminates, and you know it was a tachycardia that was AV node was part of it. So you block the AV node, the tachycardia stops. Okay, guys? Okay. Okay, case number 4. Yalla guys, we're running slow, Tara. Answer quickly. So 1 week old who was born but never discharged because he's acting funny in terms of he's always tachypneic, he's tachycardic, he's just not right. So he was never discharged. And finally, they did an ECG and they phoned us, okay, what do you think of this ECG? That's a true story, okay?
Dr. Muhammad, how to use this code
Yes.
to answer?
Sorry, Dr.
How
Abdullah.
to use this code to answer?
Yeah, Salam. So you open your camera app, okay? Pretend that you want to take a picture of this code. بعدين a link
my camera, because I'm using the phone.
Oh, okay. So you cannot do it. You should have used the computer. Sorry. Okay.
Another
Next
one.
time.
I am using the smartphone.
Yeah. Okay. Next time.
I thought there is another way.
Well, maybe there's another way, but I don't know. I don't think there's another way. You have to use another.
يا بختك يا بختك.
Yeah. Okay.
Yeah.
Okay.
I'm answering through the chat.
Yeah. I am seeing that. Thank you. Okay. So you guys. Okay. I'll see the responses now. ECG 3. ECG 3. Okay, I have 5 responses. Atrial flutter 4, excellent. 1 tachycardia. Okay, good. So yes, he's in atrial flutter. Okay, so you know, obviously there are flutter waves in between. You know, when the patient blocks, when his AV node blocks for some reason, you see nicely, flutter waves. Of course, if there is like 2-to-1 conduction, for example, here, it's difficult to see the flutter waves, but that's why sometimes if you're not very sure, when you give adenosine, always print the ECG during adenosine administration, because when you tell me, we gave adenosine, nothing happened could mean there was flutter waves that people just did not recognize, and then tachycardia went back to 2-to-1, okay? So print, let's see the ECG during adenosine, what did it, there is usually something that changes during adenosine, okay? And it's usually very helpful for cardiologists, okay? So there's sawtooth appearance, rapid, usually very fast atrial activity, very, very short, way faster than 200 beats per minute, okay? So look here, it's very fast, okay? Of course, more P's than QRS's. And then in the EP lab, it's usually, you see this is a patient of ours, by the way. He was like 14 years old who was in flutter, not this patient. Anyways, the tachycardia circulates around the tricuspid valve. This white thing is the atrial activity, okay? So it just keeps rotating around the tricuspid valve. And how you treat this tachycardia is you ablate, you create a line of block between the IVC and the tricuspid valve. Because the IVC, there's no any muscles here anymore. And tricuspid valve, there's no muscles, so the tachycardia would not be able to turn around the tricuspid valve, and then it will stop. Okay, guys? So it's a line of block that you create in the EP lab between the tricuspid valve and the IVC. Okay? Okay. Okay. Questions? I proceed? Okay. And then, by the way, just to talk about this really quick, because again, this was meant for medical students. So atrial flutter in babies, the treatment is what, guys?
Cardioversion.
Hello, cardioversion. You cardiovert, and usually stops, of course, and then it never comes back. Okay, except super duper rarely. Okay. So you cardiovert. Where do you place the pads?
You said it before. One pad will be posterior, something like that.
Yes, one anterior, one posterior. Okay, because the atria is yani posterior. Okay, the left atrium is posterior, and they are like they are posterior structures. So you want to hug the atria. You put the anterior pad a little bit leftward, but central, and the posterior pad a little bit rightward and central. Okay, don't place them as if you want to cardiovert a VT or a VFib, and you put one at the apex, one at the upper chest. That way you're not hugging the atria. You should hug the atria anterior posterior. That's the best. Okay, that's the least required energy in order to cardiovert atrial flutter. Okay, so anterior posterior pad. So often the pads are placed incorrectly, and people tell you, people say flutter did not cardiovert with cardioversion, just because the technique was incorrect. Okay, and of course should be synchronized, right? Synchronized cardioversion. You want to synchronize the defibrillator to the QRS, okay? Because you may, if you do not synchronize, you may induce VFib, okay, guys? So patient goes from being stable to very unstable, of course, okay? So synchronized cardioversion, anterior, posterior pads, and 0.5 per kilo should be super easy to disappear, to cardiovert, okay? Okay, usually you cardiovert, make sure there's normal function, normal echo, and often realistically you don't need to follow up with them. Usually we see them once or twice and then we just discharge. Okay. Okay. Case number 5, couple of days old. This is like one of my first patient encounters when I came. This is a patient who was not a chest, but he was somewhere else. I don't remember when. He was a preemie, dysmorphic, had metabolic acidosis. He was hyperkalemic, hypothermic, not intention. He was hypothermic by himself, and he had like LV non-compaction, and this was his ECG. So answer, please. Okay, guys, that's enough. Okay, right? Yalla, please answer. Okay, thank you. ECG 4, where are you? ECG 4. Okay, good. 7 responses. That's good. Okay, the majority said 2-to-1 AV block. Excellent. Someone said, one said complete heart block, one said Mobitz 1. Okay, so Mobitz 1 means there is progressive PR prolongation, then drop beat. So usually you see grouped beating. بمعنى you see a couple of beats back to back and then a gap. Couple of beats back to back and then a gap. Okay. whenever you see grouped beating, then يعني, of course Mobitz 1 comes in mind. In this case, the RR interval is regular here. There's no group beating, okay? And there's no drop beats. So Mobitz 1 is definitely not the answer. Type 1 heart block is you have 1-to-1 conduction, but fixed PR prolongation. So the question is, do we have 1-to-1 conduction here, or higher grade AV block? So I mean, yani there is, so this is his P wave, sinus P wave. There's definitely something very funny in this T wave, right? So this T waves are never this sharp, okay? And then this deflection is like almost identical to the P wave, right? So I mean, so this is a P that block and this P that conduct, and then this PP interval is, and I'll show you, it will march out nicely. So that's an example of 2-to-1 heart block, okay? If you are thinking this patient has first degree heart block, I told you this is a couple of days old. So then you have to say, why is this baby is having first degree heart block plus sinus bradycardia? And you're giving him two diseases. And if the baby has first degree AV block, usually he's not bradycardic. It's just first degree AV block without bradycardia. But in this case, there's definitely no sinus bradycardia, just 2-to-1 conduction, and hence the QRS rate is slow. Okay, guys, makes sense? So there is regular PP intervals, regular PR intervals. Each P that conducts has a fixed PR interval. In this case, a little bit long, right? So the P that conducts is with first degree AV block, but there is a higher grade AV block. So you don't say first degree, you mention the highest grade within the ECG. Okay, the P waves are coming from the sinus node, and hence they should be conducted. Sometimes if the P waves are ectopic, the AV node may block them. So it's unfair to assess the conduction if the P waves are not sinus. Unfair for the AV node, So if the P waves are sinus and they are being blocked, so then definitely the AV node is diseased, okay? Okay, makes sense, guys? This is an example of a nice example of 2-to-1 heart block, okay? This patient was he was very funny. I mean, he passed like, a couple of hours. I mean, he only lived for a couple of hours or maybe a day or two, and then he passed with other, he has multiple issues. So we never figured him out. We did not do genetic, but there must be some genetic, mutation. Okay, guys? Question? I proceed? Okay.
Dr. Muhammad, معلش.
Yes.
The only difference between 2-to-1 AV block and the Mobitz type 2 is there is no drop the beat. And we can differentiate by the drop the beat only.
Mobitz 1
or other. This is 2-to-1 AV block.
Yes.
I can't differentiate it from Mobitz type 2 by only drop the beat.
So Mobitz 2 means there is dropped beat or P that's not conducting without preceding PR prolongation. Okay? How the definition of Mobitz 2? There is dropped beats, P waves, but the preceding P wave was not gradually prolonging. That's Mobitz 1. So in this case, because it's 2-to-1, you cannot tell whether this AV node block is Mobitz 1 or 2 because there's only two P waves, so you cannot tell whether it's prolonging gradually or not. Okay, so that's why it's a separate identity. It's called 2-to-1 AV block. So when I say 2-to-1 AV block, this could be Mobitz 1 or this could be Mobitz 2. You cannot tell. Okay, but the difference between Mobitz 2 and Mobitz 1. Mobitz 2 is a P that drops without preceding PR prolongation. Mobitz 1, P drops with preceding PR prolongation. Okay?
Yes.
Okay.
Okay.
Okay. Case 6. So baby, a newborn, just born, with distress.
دي سهلة إن شاء الله.
Okay, ready guys? Okay, now the ECG number 7. Okay, only 5 responses, guys. Yalla. Okay, so majority said complete heart block. Okay, excellent. Someone said Mobitz 1. So again, Mobitz 1 is fixed PR. Sorry, Mobitz 1. Mobitz 1 is gradual PR prolongation. Here, PR is all over the place. ما في pattern. يعني this is طبعا plus Mobitz 1 there is a drop beat صح؟ فهني قلنا
Yes, no drop the beat.
إلا رقم ما في drop beats. Okay, so you cannot say Mobitz 1. Okay, and then if you pay attention to the PRs يعني
And are regular. Are regular.
yes يعني مثلا here PR بعدين there is another P here that blocks بعدين here there is P بعدين P that blocks والPR هذه غير عن هذه يعني it's all over the place. Okay, so definitely not Mobitz 1. Yes, it's tricky, but you have to يعني know the definitions and hence answering يعني you know the questions. Okay, you know how to read the ECG. So this is complete heart block. There is complete dissociation between the P's and the QRS's. The RR interval is usually regular. The PP interval is generally regular, but maybe a little bit irregular. So that's not a must, but often the RR interval is regular. There is PR intervals all over the place. It's a regular interval. And the P waves are coming from the sinus node again, because again, the AV node should conduct sinus activity, may not well conduct non-sinus activity. And the P's are more than R's, meaning the patient usually is a little bit tachycardic because he wants to compensate for decreased cardiac output. Okay, so this is a baby, so the sinus rate here is around 150. So that's normal sinus rate for a baby, but of course the RR interval is slow. Okay, the ventricular rate is slow. Okay, guys, that's very commonly seen in babies, so everyone should recognize that ECG. Okay, and then of course Mobitz 1. It's generally benign. Complete heart block is complete different, and it's different beast, different animal. Okay, and more intervention is very different. Okay, so urgent arrhythmias are generally SVT, flutter, heart blocks. Okay, these are your urgent arrhythmias. Okay, and then the ECGs that you should not miss. But they are not they're not like urgently now, but you should not miss because it may have consequences down the line. Okay, so that's case 7. This is a 5 years old who fainted while swimming. It's a real story, and there is family history of significant family history of fainting. Okay, guys, let's see. This is ECG number 1. Where's ECG number 1? Okay, so good. There are 7 responses. So usually we're getting 7 responses. I don't know why, but I guess some people are not using their laptops. Okay, long QT interval. Perfect. So majority said long QT interval. Ischemic changes and Mobitz 2. Okay, I don't know why someone said ischemic. Ischemic changes, I see why people may wonder about ischemic because the T waves are abnormal. But more importantly, the QT is very long. So QT with true long QT syndrome, not only the QT interval is prolonged, but the T wave morphology is also abnormal. Okay, so I understand the ischemia confusion, but with ischemia, generally the QT would not be super long. Okay, and Mobitz 2, I'm not sure why someone said Mobitz 2, but here in this case, PQRS, 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 there's normal one-to-one conduction. Okay. There is no P hidden in the T wave, so there's no heart block. Okay, so that's a 5 years old kid who had his sister has long QT syndrome, and she was on Nadolol. He was never screened because the family are just a little bit reluctant to screen their kids. But he fainted, and finally they did show up in clinic, and then this was his ECG. And then Dr. Mitwalli, I think this is you told me about this ECG if you remember. I don't know whether
yes.
Yeah. So
I think.
Yeah. So I think I'm sure you remember. So indeed this sibling also has long QT syndrome, and he fainted a couple of times. Well, this was I think the second time, and then he fainted the third time. We admitted him. We maximized his Nadolol dose, and we referred him for sympathectomy. We did not do sympathectomy here, but he's currently in Saudi Arabia, and he's scheduled for sympathectomy in a couple of weeks. But he's from Saudi Arabia, and we unfortunately don't have pediatric surgeon that is expert in sympathectomy. But fortunately enough, Saudi Arabia they do, and they are from Saudi Arabia. So he was referred, and now he has an appointment next week. So they will do sympathectomy there hopefully, and he'll come back. He lives in Kuwait, so he will come back with Nadolol and sympathectomy. Hopefully they give him a good sympathectomy. Sometimes we do often we do left sympathectomy, and then if still he has complaints of syncope or he still has non-sustained torsades, we do right sympathectomy, and if he's still having symptoms, he needs an ICD eventually. And then if he still has symptoms on ICD, eventually maybe transplant. Okay, but this is very unusual. But usually with sympathectomy and beta blockers, that's good enough. Occasionally you need ICD as well. Okay, it's okay. So his syncope is likely because of torsades, and I guess everyone knows that long QT, patients are at risk of torsades. Okay. So the T waves are bizarre, and there is definitely prolonged QT. In this case, the machine is measuring around 600, and when we measure it, yes, it's definitely 500, north of 550 to 600. So it's very long. Okay, and of course when so he's definitely at risk of repeated, torsades. Okay, with Nadolol, it's eventually he was discharged with a QTC of around 520. So it was still prolonged, but I mean there's nothing we could do except giving him an ICD. But I think it's unfair for the patient to get an epicardial ICD, and there is an option for sympathectomy. So we pushed for sympathectomy, and we arranged for sympathectomy to be done in Saudi Arabia after multiple emails and calling, but finally it's done. Oh, well, it's almost done. Okay, and he's so far so good. Okay, okay, case number 8. Okay, yalla. Try to be good, guys. Huh? ECG 12.
محمد wait 3 minutes second يا دكتور محمد wait
3 minutes. What happened?
meeting. Yeah. First message. اوكي يلا علي خلصت؟
since long time.
ثواني هغير اجابتي، ثواني هغير اجابتي.
لا تشك بعمرك يعني، خليك على الإجابة الأولانية.
دكتور اسماعيل
ينفع
has
نغير الاجابه اصلا؟ ما ينفعش صح؟
ما أدري والله.
لا ينفع
ينفع
دكتور اسماعيل has a good او dramatic schema for the block. Yes, he teaching us block in the group.
اليوم the most active ما شاء الله يعني.
الله يسامحك يا علي.
الله يسعدك دكتور اسماعيل.
ما شاء الله اليوم the most active يعني. فجود يلا انزين.
ده عشان هايبر ثايروديزم يا دكتور.
انزين ف موبتس 1 3 موبتس 2 1 هاي جريد 1 اوكي فيعني good. طبعا again this is يعني هذا الجروب beating اللي I'm mentioning. ففي group beats gap and then group beat. طبعا I wish I have a longer rhythm strip but يعني group beats gap okay. فهذا it's a sign of irregular beats. This patient had just يعني someone felt his pulse that was irregular and did an ECG. He has no complaints okay. So the P, this is the PR and then prolongs طبعا gradual prolongation and then eventually blocks okay.
Yes.
The next P is back to short and then long and so forth.
Yes.
Okay. So
Clear.
Yeah. Mobits 1 gradual PR prolongation cycle repeats itself okay. Okay. انزين يلا case 9. يلا this is يلا 10 more seconds.
finish. انا عايز اقول لكم حاجه عشان الكود يتلقط معاكم بسرعه. حاول تخلي المربع بتاع الكاميرا اكبر من المربع اللي قدام، يعني وانس ان انت خرجت بره الحدود هيلقطوا على طول.
There is many programs for code دكتور اسماعيل. You can use any program and very fast. I use program actually. I use one program for codes.
محتاج كود يعني مش محتاج كود.
محتاج كاميرا بس زي المنيو بتاعت المطاعم.
اي كاميرا عاديه.
Yeah, it's so easy يعني المفروض
هو وانس ان انت بس المربع بتاع الكاميرا خرجته بره اطار الكود ده هيلقطه على طول.
Samsung there is some difficulty with Samsung actually. For iPhone iPad very easy.
Yeah, buy iPhone next time.
Buy iPad easy.
Okay, good, easy. www, everyone's a www. Okay, nice. طبعا short PR delta wave. Okay. طبعا with www نفس ما قلنا if you have an abnormal depolarization, for example www, your ST segments may look a little bit funny. يعني in this case يعني they may not look super funny but they may look super funny. Plus the QRS axis may يعني in this case في يعني there is left axis deviation right. But because there is an accessory pathway, so the average ventricular depolarization is changed because of the accessory pathway. يعني usually there's only one route to the ventricle which is through the AV node and his Purkinje system صح. will average depolarization is this way leftward okay. طبعا if you have an accessory pathway you have a different يعني the vector will change. So accordingly, it may change your QRS axis. So in this case, there's left axis deviation. But once you read this ECG, you don't say there's left axis deviation. You just say normal sinus rhythm with WW. And the axis deviation here doesn't make is meaningless because there is WW. So you cannot interpret the QRS. Okay. You cannot say there's a method. For example, someone may say, "Oh, there's a segment depression. I worry about ischemia." Again, it's an abnormal depolarization. Then I wouldn't worry about a segment change unless there's a clear history concerning history. Okay, here maybe there's a segment elevation, but again, it's not relevant. Okay, short PR, delta wave. Of course, people it predisposes to SVT, and there is risk of the atrial fibrillation with rapid ventricular conduction and VFib, okay, or sudden death, okay? Okay, next, okay, others, yeah, we're towards the end, okay? Okay, case 10. Yeah, these are ECGs are usually benign. I won't worry about them so much, okay? احنا down to this category now. Okay, يلا. Okay, ECG 4, where are you? Sorry, wrong. ECG 4, where are you? Okay, mashallah, 12 responses. Okay, good. أول مرة 12, 13 responses. Okay, everyone responded. It's a mixture of answers. Okay, معقولة هذا ال ECG 4? Yeah. Okay, so that's strange. Then 6 said 2-to-1 heart block. 6. Okay. Who said 2-to-1 heart block? يعني 6. Someone said to heart block. 2-to-1.
فيكسد برونجد بي ار.
فيرست ديجري هي فيرست ديجري.
فيرست برونجد بي ار فيكسد ديز ار ريجولار فيكسد برونجد بي ار.
Okay, but who said يعني 6 people answered 2-to-1 conduction. يعني someone tried to defend your answer. يعني maybe I'm not seeing something بس يعني
maybe team is the like B in B2.
Yeah,
هم اتلخبطوا في البي اللي في النص.
I don't know يعني you can speak up, don't worry يعني whoever said 2-to-1, but يعني this T wave looks very clean to me. If there is a P wave that's hidden, remember I didn't say he's 18 years old, okay? If there is a T wave that's hidden, let's say somewhere here يعني, then you are then the sinus rate is like 150. يعني 18 years old with a sinus rate of 150 doesn't make sense, okay? فالage and 2-to-1 doesn't make sense in this case. Plus, the T waves are really clean, and I don't know why the confusion of 2-to-1 heart block. Okay, so usually if there's 2-to-1, again the P wave they are marched nicely, and there is one here and the one here and the one they should be regular. I don't see any hint of a P wave hidden anywhere. Okay, so I don't know why the confusion for 2-to-1. Okay. So it's first degree, okay? I don't know why this is confusing to many people. I don't know. I see complete heart block. I see S-signal elevation. I see sinus bradycardia. Well, yes, it's a little bit sinus bradycardia, but he's 18 years old, so he's not really pediatric, okay? Make sense, guys? So there is fixed PR prolongation, okay? Fixed PR prolongation, okay? So the PR is just, there's 1-to-1 with PR prolongation, so that's first degree. Usually benign. May not be benign, but usually benign. Okay, case 11. Okay, yalla.
Wait one second.
Okay. Only 2 responses, so people are confused.
ممكن
Yes.
ممكن حضرتك تكتبها اكتر؟
Yes, yeah.
أكتر.
Okay. Okay. Yalla, only 4. Okay, so you know, it's something non-sinus. This is the teaching point here, that the P wave are definitely inverted, right? Okay, definitely inverted. What the options I said, the left ventricle. Okay, so you know, so sinus P wave means of course, the atrial activation is coming from the sinus node, and the sinus node is located at the upper right atrium between the SVC and the atrial appendage. Okay, so the atrial active vector is, you know, up superior to inferior, right to left. Okay, so left leads will have positive P waves, and inferior leads will have positive P waves. Okay, so normal P wave axis is between 0 and 90, upright in left and inferior leads. In this case, this is the P wave is negative in the inferior leads. So the atrial activation is coming from below, like the atrial activation is coming from below up. Okay, so definitely low right atrial rhythm. In this case, right because the P wave is positive in lead 1, so you know it's going right to left. So low right atrium. Okay, makes sense, guys? So P wave axis is very important. You have to know it because, you know, by this way, you know what's atrial tachycardia, what's sinus tachycardia, what's sinus node dysfunction, what's, you know, and all the varying atrial rhythms. Okay, so if you have non-sinus rhythm, you ask yourself, are we tachycardic or bradycardic? And for tachycardic, then do we have narrow complex tachycardia or wide complex tachycardia? And accordingly, you figure it out. And if you're bradycardic, then it's usually you have sinus node disease, or you have someone with heterotaxy without normal sinus node, and hence the atrial activation is coming elsewhere. Okay. 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 So case 12, it's 1 day old, trisomy 21, murmur, screening ECG. He's fine, but just has a murmur and a little bit. Okay, that should be easy. Okay, guys. CG8.
دقيقة بس يا دكتور محمد.
محمد ويت يا دكتور محمد ويت بس ويت.
دقيقة.
2 seconds يا دكتور.
مش سهل للدرجات دي.
اسماعيل بيحل في آخر سؤال. خلص آخر سؤال خلص.
اسماعيل اليوم ما شاء الله active. Okay, خلاص. Okay, only 3. Okay, okay. طبعا left axis deviation. Okay, so the QRS is going away from the inferior leads. Again, this is our nice, lovely cartoon here. So the QRS vector is going away from the inferior, it's going this way. Okay, it's going north. Okay, so this is your
محمد شكلها اكستريم اكسس ولا ليفت اكسس ديفيشن؟
ليفت اكسس يا علي.
ليفت؟ اصل ليد 1 نيجاتيف ولا ايه؟
ليد 1 is more
ايكوفوكال
اكستريم لا
يعني
لوكس اكستريم اكسس ما هو
ممكن كانت ملخبطاني في الاول فعلا، بس ما لقيتهاش في الاجابات يا علي، مش موجوده في الاجابات.
انا ما اخترتش.
انا ما عقدتها انا honestly I just think the answers were left axis deviation, right axis deviation, for definitely not right axis, or not right, not normal. Okay, It's somewhere يعني north. طبعا we can talk about it exactly where it is, بس طبعا does it make a clinical difference? Not really يعني so much. يعني you'll do an echo and you'll figure it out, صح؟ بس يعني this was an AVSD طبعا trisomy 21, so they always have left axis deviation. Okay. Case 13. شو اسمه sensation of irregular beats. يعني kid or 6 years old يعني complaining of irregular beats. Okay. اوكي سهل صح؟ زين؟
سهلة دي سهلة ان شاء الله.
اوكي فيعني طبعا there is extra beats.
Ventricular.
They are wide, not preceded by a P wave, so they are طبعا ventricular beats. Okay. ECG. طبعا only 4 responses. I don't know why, but everyone said PVCs. Okay, excellent. So there is, wide QRS that without a preceding P wave. The T wave is super clean. This T wave is identical to this T wave. There's no, it's not atrial beat with aberrancy. Okay. And then last one, 4 weeks old bradycardic, ECG for bradycardia.
اقفل المايك يا
ماشي.
اوكي
نروح للاختلافات.
تمام.
اوكي
ECG 6. Only 2 responses. Okay, only 2.
Me and Ismail actually.
wait دكتور محمد.
يلا wait.
هي صعبة دي صعبة شوية. مش عارف.
اسماعيل بقى اللي عنده السكيما اللي بيطلع
والله عندي تعبين.
والله يا دكتور محمد سكيمة سحرية والله.
مش هنعرف.
دكتورة تخفيف. جبت دكتورة تخفيف.
اوكي يلا لسه 3 نص ساعة اعطيتكم لسه 3. اوكي هاي صعبة 3 وكل واحد
دي صعبة.
واحد ساينس بديكاريا، واحد موبتس 2، واحد كومبليت هارت بلوك. اوكي دي صعبة I agree. اوكي
هي فيها ميكس يا دكتور محمد.
وكلكم غلط يعني.
طبعا. توالي في بلوك.
اوكي اوكي I did not expect this to be that difficult. اوكي طبعا PQRS funny T wave صح؟ Right?
Yes.
Okay. There is sharp deflection in the T wave.
Yes.
Bradycardia. What do you think of when you see this?
Yes.
What comes in mind? يعني P
2 to 1
لا يعني بلوك دي بيت
بلوك P wave صح؟ بس ال P wave بس it's not 2 to 1 ليش؟ لأن ال P is very early. احنا قلنا 2 to 1 ال P راح يكونون regular صح؟ كذي regular. In this case
بلوك بي سيز.
هذا in unitology دكتور عبد الله التهامي يعني is he attending here. in neonatology, they see this very often. It's baby with bradycardia, more complete heart block. It's just frequent PECs that are being blocked. Best, sometimes they conduct, بس يعني طبعا they conduct البيبي يصير tachycardic. If they block البيبي يصير bradycardic. Okay, ليش bradycardic؟ لأن ال P wave D inhibits the sinus activity. يعني sinus node it gets inhibited if there's an extra beat. Okay, يعني هذا sinus node, there's a PEC coming from here, goes blocks here, sorry, but goes upwards, infiltrate the SA node, or resets it. Okay, so you get compensating pause, and then functional bradycardia. Okay, if this PEC conducts, then you get طبعا tachycardia. It's a different problem. Yes, this is a patient who is physiologically behaving like a 2-to-1 heart block or even complete heart block because it's bradycardic. But in this case, the treatment is not pacemaker. The treatment is electrolyte. If there's electrolyte disturbance, you correct it. And in fact, you give anti-arrhythmics. It doesn't make much sense. You are a bradycardic, but we want to inhibit these PACs by anti-arrhythmic drugs. طبعا good one is flecainide because there's minimal sinus decrease activity with flecainide. But طبعا some people also use beta blockers. طبعا beta blockers may worsen the case initially, but eventually they will probably help. But I think better drug of choice would be flecainide. And flecainide doesn't slow your sinus rate as much. That just inhibits your sinus, your PACs, and hopefully the heart rate would be normal. Okay. In this case, just to complicate things, the P waves here, they did not reset the sinus node. So in here briefly, there was no bradycardia. Because this PAC blocked before the sinus node, there was no reset. Okay. This is an interesting finding. Anyways, so. Okay, so these are premature beats, often benign, unless there are runs or they are polymorphic. And I'm talking about PVCs or PACs. They are usually benign unless they are polymorphic. There are runs, very frequent. There is family history of death, ولا cardiomyopathy, ولا unexplained syncope. And there's something funny in the family history. And they may cause bradycardia. You want to use antiarrhythmics despite the bradycardia. طبعا you do echo Holter if to screen for هالسوالف, runs with polymorphic or frequency. But if it's a baby, usually it's day, 2 days, 3 days, but then it goes away usually. Okay, طبعا if not a baby, then it will not go away if the patient is not a baby. It usually doesn't go away if you need to do echo Holter to measure average rate, burden, maybe MRI if you're suspecting cardiomyopathy or myocarditis or something. And of course, you take good history and family history. Okay. Okay. I don't know, we're taking so much time, but I was just gonna say something about Q waves. Q waves are normal ventricular septal depolarization. Okay, and they are present in lead 1, 2, 3, AVF, and V6. So if you see Q waves that are present elsewhere, you think could be an abnormal finding, or if the Q waves is wide, then could be an abnormal finding. So duration of the Q is very important. If it's abnormal, it may indicate infarction or history of infarction. If it's tall, usually tall is less sensitive. Tall people may accept up to 8 small squares, especially in lead 3. Ismail, you noted a Q wave that is tall in one of the ECGs, but this is a benign finding. Okay. Okay. Again, Q waves are usually seen 2, 3 AVF or V6. Okay. So you always look for the normal Q waves. Okay. Okay. طبعا if you have RSR prime in V1, that's right bundle branch block. I have to move, I guess, because we're taking forever. Okay, and if you have P wave that's big, it's right enlargement. If you have P wave that is bifid or fractionated, that's left atrium, because the RA starts normally, but then left atrium that's diseased, for example, starts later or ends later. If you get more bifid, if you have just isolated right atrium, you get big, large ones, P wave. Okay, T waves are usually upright and at birth, but then invert, but then they are back to upright. Okay. Okay, pay attention to the calibration and paper speed. Okay, I think we are done. طبعا last thing, artifacts. Artifacts, many people call me, what's this, what's that, and it's artifacts. So for example, if you see, these are small ECGs, sorry, but if you see two QRSs that are back to back, and this is non-physiological, it's impossible. You cannot have two QRSs that are 40 milliseconds apart, okay? The physiological rate, non-physiological rates are usually artifact, plus a true QRS would produce a T wave. If you see a QRS without a T wave, that's artifact, okay? So you have to see T wave for each and every QRS. There doesn't exist a QRS, it's impossible to have a QRS without a T wave. Okay, and then, if you see bizarre activity, baseline activity, someone called me about this ECG, this is a patient in flutter, but this is just artifact. Okay, these high frequency signals are not 3 QRSs, these are artifact, okay? You see one lead here, and you see maybe fibbish waves, but then another lead, it's normal P wave activity, then this is artifact, okay? So pay attention to artifacts. Don't let the artifact confuse you, okay? Okay, I think we're done, okay? Best خلاص, okay?
Thank you.
Okay. Questions?
شكرا جزيلا دكتور محمد.
Okay, thank you. Okay, thank you guys.
شكرا دكتور محمد، ربنا
Thank you
يكرمك.
very much.
Okay. يلا مشكورين، مع السلامة.
شكرا، مع السلامة.